Welcome to the 50th anniversary of the VEITH meeting. Hard to believe. I am joined by the leaders of the BEST CLI trial, one of the most impactful NIH trials done in our career. And I'm going to start off by asking Matt Menard. So tell us what the status of BEST, since it's been published, what have you heard from your colleagues?
Yeah, thanks, Michael, and happy anniversary, Frank. So a lot of buzz about the trial. You know, it's a chance to really sink our teeth into some real data, and there's been obviously a dearth of that. And so I think people are just really enjoying, trying to understand what this trial means for their own practice, what it means for their own disciplines. How can we continue to collaborate to answer the next series of questions. There's a lot of new data that's coming out in the near future.
Let's go on to that. I'll turn to Alec Farber. So there have been a couple of publications out of BEST since the initial manuscript. Tell us a little bit about those, and then what topics are you looking at for the future?
Well, we have been very busy, Michael, since the publication of BEST, and our team has been working on up to 30 projects that are about to come out. We're going to be releasing information about reinterventions, about amputations, about a survey of BEST CLI investigators. We also have plans to do a as-treated analysis, whether bridges are burned, and various subgroup analyses for chronic kidney disease, diabetes, and much, much more.
So a treasure trove of data that could really further impact the field. Ken Rosenfield, you've been doing a lot of clinical trials in your career. From the cardiologist perspective, what have you learned about BEST since it's been published, and what are your colleagues saying?
Well, I think it remains this seminal trial, really, in our space, and it clearly, I think it's reset the bar a little bit for all of us. Again, the original purpose is endo first always the right thing, and the answer to that's no. I still think we need to parse out exactly which patients. Doesn't mean that endo's dead. I think we need to parse out which patients are going to be better with each therapy. And it's interesting because it's a moving target. As therapies get better, this also may evolve too. As was pointed out by Matt, it opened up doors for even more questions to be asked. And I hope we get to the angiographic analysis, which will be really helpful to us to understand which patients are better for each therapy.
And Mike, you've been doing a ton of clinical trials. You were really intimately involved in this one. Last year at this meeting, one of your conclusions I remember was, listen, what BEST taught us is if you're seeing a patient with CLTI, you should do a vein map and then decide if they fit into the first cohort of BEST CLI. So now you've had a year to reflect on this. You've had a year to speak with your colleagues. Other data has come out. Tell us, is that still your recommendation and your practice?
Yeah, I think that, what the trial has shown us is that we need to figure out which patients are really best served by one or the other, but that we need to take an overall approach at staging the patient, looking at whether that they're a candidate for surgery at all, what their goals of treatment are, and then, what's the anatomy of their disease. If they are, a simple endo case, I don't think we're going to be doing vein mapping on those patients. I think there's a big group of patients that are in the middle where they could go either way, and I think knowing all your options up front before you decide how you're going to start intervening leads to the best decision and decision making with the patient. So to get really to an area where we're doing really informed decision making, more in line with coronary treatment, we're really talking to the patient about what their options are and what might be best. I think we need to have all the data up front before we start the procedure, especially for those patients who are reasonable candidates for surgery.
And sticking on this, one of the most common debates that I've seen in meetings since BEST and Basel II have been published is, what's the story? Two large randomized trials, theoretically the same patient population, two different answers. So I'm going to ask each of you, how do you rationalize that to your colleagues? So we'll start with you, Mike.
So there's a lot of work to do still to unpack these two trials, and the two trial teams are working together right now to try to figure that out. So there's a lot that we don't know about who the patients are exactly in the two trials and how their care was delivered. But what we do know is a couple things. One is that BEST is larger, 5 times the size, and has a broader inclusion criteria in terms of the disease anatomy and complexity. It looks like the basal trial had somewhat higher or more frail patients with generally poorer outcomes long-term from surgery in terms of mortality. But I think the best trial is bigger, broader, more inclusive in terms of the criteria for enrollment. And so what we need to do is figure out in more detail how these populations match. But they're also different healthcare systems, different delivery. We may not be able to sort it out, but we're going to try.
Alec, how about you? How do you put those two in context?
Yeah, I completely agree with Mike. We are working very hard with the basal investigators to harmonize these trials. And of course, there are issues, there are differences between the trials, as Mike mentioned. We'll do the best we can to create a single story that can sort of answer the questions that people are asking. And that is priority number one for us.
Ken, one of the comments that was made during the Basel II presentation was the difference in the specialties who manage CLTI overseas in Europe compared to the United States. I don't know if you have any thoughts about how do you put the two stories together, particularly with that lens of does it matter which specialty does what?
It's a good question, Michael. I kind of don't want to go down a pathway of divisiveness. I actually think we need to work together as best we can to figure out the answer about which patients. Clearly, technical skills make a difference. But no matter what specialty is doing these procedures, I agree with my colleagues that we're just starting to scratch the surface here. The trials may not be able to be harmonized exactly, but I think we'll learn a lot from each, and that'll inform the next series of trials that we really need to. I think the challenge for us is let's figure out together what are those next trials, and let's embrace them and do them and randomize appropriately so we can really learn the answers that have done in coronary disease.
That's a perfect segue, Matt, to the last word here. So, it's exciting. 2 major landmark trials in this patient population who sorely need clinical data in order to help advance the care. But take a moment to reflect, Matt, on the experience of conceiving and running BEST. What did you learn as a researcher? What are the tips that you would give to the audience if they're thinking about getting involved in clinical research in a scale like this?
Yeah, first I'd say, Michael, to anyone out there, do not be dissuaded from obstacles that are going to be put in your path. BEST was successful in Basel II because the clinical question was of such high interest, and there are so many, to answer the question you asked, everyone else, BEST and Basel are the very beginning of hopefully a much longer journey to identifying all the secondary, all the tertiary, all the many questions. And so, if you have any inkling, there's so many questions that need to be asked, so dive into it. And, it's hard, but it was very rewarding, and, hopefully it helped the collaborative spirit that Kenny was referencing, that we absolutely need to get beyond the cardiologist versus surgeon, open versus endo. It's all just, bigger picture. What's the best thing for the patient, and how can we figure that out?
From New York City, I think we'd all like to say congratulations to Frank for 50 years, and we're looking forward to many more.